I should start with a little bit of background in that this was a secondary analysis of data from a previously presented and previously published randomized trial. And the basic idea behind this analysis is that we don't have a great understanding of how integrated specialist palliative care might be improving patient-reported outcomes among patients with acute myeloid leukemia. And we did find in our prior trial that was actually presented at the ASCO meeting just last year by my colleague, Dr. El-Jawari from Mass General, that when we randomized patients with AML who were admitted to the hospital to receive high-dose intensive induction chemotherapy and assign them to either integrated specialist palliative care or routine leukemia care, we found that those patients who received the intervention did have pretty significant improvements in patient-reported quality of life, anxiety and depression symptoms, and post-traumatic stress symptoms, both at the primary endpoint time point of the trial, which was 2 weeks into their high-dose chemotherapy hospital stay, but actually also sustained out at 6 months. But as I mentioned at the start, it's not exactly clear how those benefits might be conferred. And so this analysis that we're presenting at this year's ASCO meeting is a mediation analysis focused on one area that we think might be particularly important in actually mediating those outcome improvements. Ultimately, we were interested in the question of whether coping and coping styles might be associated with these outcome improvements in patients who received integrated palliative care compared to those who did not. And the rationale there is that this has been shown in some other studies and analyses looking at the effects of integrated specialist palliative care in patients with solid organ tumors. For example, the work of Drs. Temmel and Greer and Jacobs and others at Mass General showed this a few years earlier at a prior ASCO meeting, that actually the effects of the palliative care intervention on facilitating more positive kinds of coping, or what we would call more adaptive, kind of active, positive coping, seems to explain a significant proportion of the impact of palliative care on improving patient-reported outcome measures. So we wondered if this might be the case also in this hematology population, but felt that this needed to be examined separately in this separate population too, because it's such a different group of patients. It's a very different disease, really sudden onset. Sometimes these patients die relatively soon. They have a really sizable side effect profile. They're treated in the hospital rather than in the clinic. So very, very different than how most patients with advanced lung cancer or non-colorectal GI cancers might be seen and treated. And those are the kinds of patients who have been the focus of prior analyses. So when we examined this issue, this question of coping styles in patients with AML, we did indeed find that these AML patients who received integrated specialist palliative care were far more likely to exhibit more positive coping styles compared to those who did not receive the palliative care intervention. And that was true at the 2-week time point, where we saw a lot more of that positive coping and less of the negative coping there compared to what we saw in the control arm patients who did not receive the palliative care intervention. And this was sustained over time in the intervention arm patients, where they were more likely to maintain that sort of positive coping style even to the 24-week time point. When we did the more sophisticated mediation analyses, and these are really challenging to describe, but I will do my best to do it kind of quickly and efficiently here, we basically found that this change in coping accounted for a sizable proportion of the intervention effects on the outcomes of interest. So for example, if we look specifically at quality of life, we know that the integrated palliative care interventions significantly improved patient-reported quality of life at the primary time point of 2 weeks. And when we did the mediation analysis, we found that actually the change in coping appeared to mediate about 78% of that intervention effect on improving quality of life. Similarly, when we looked at depression symptoms, we found that the change in coping appeared to explain about 66% of the intervention effects on improving depression symptoms at 2 weeks. But then when we looked at anxiety, it appeared that the change in coping explained quite a bit less of the intervention effects on the anxiety outcomes, anxiety symptoms reported by patients. In this case, it was only about 35%. So there may be something different going on there in how integrated specialist palliative care improves patient-reported outcome measures. It seems to be that the change in coping significantly impacts quality of life and explains most of that change, and also explains most of the change in depressive symptoms. But there may be something else that explains the improvement in anxiety symptoms that we've seen with this intervention. So more research is needed to better understand that. But it may be, for example, that focusing on other kinds of issues besides just coping styles could be improving anxiety. For example, helping patients with symptoms associated with their chemotherapy treatment might be helping with their anxiety issues. And we know that symptom intervention is actually a significant part of what palliative care specialists often help our patients with, in addition to what we're doing with routine cancer care.